Leti, 6:30.
Ok, ¿empiezo? Muy buenas noches a todos. Es para mí un honor darles la bienvenida a nuestro primer webinar organizado por CISIDAT, hoy Consorcio de Investigación en Salud, la cual tiene la función de favorecer el desarrollo de la investigación tanto en nuestro país como en el extranjero, contando con diversos apoyos para investigadores nacionales y extranjeros, como la elaboración de propuestas de investigación, apoyo presupuestario, análisis estadístico, redacción de publicaciones y traducción del conocimiento. En esta ocasión es para mí un honor darles la bienvenida a este webinar en conmemoración del Día Mundial del SIDA, que desde 1998 tiene la función de concientizar y dar a conocer problemas, avances, retos que se tienen en relación a esta enfermedad. En esta ocasión, este programa ha sido posible gracias a un apoyo parcial y restricto por parte de Vivhealtcare, GSK México y CISIDAT. Estamos con tres excelentes ponentes. El doctor Charles Hicks actualmente se unió a Vivhealtcare desde el 2017, perdón. Tiene una experiencia de más de 30 años en medicina académica, inicialmente en Duke University y posteriormente en la Universidad de California en San Diego, con una amplia carrera en el desarrollo como mentor, maestro, médico e investigador en el área de VIH-Sida. Desde noviembre del 2017 forma parte del equipo de Vivhealthcare como director médico global senior. Es autor de diversos artículos internacionales indexados. Durante algún tiempo formó parte de un grupo de investigación del AIDS Clinical Trial Group, y así como una gama de diversos revisores y asesores, diversos paneles. Contamos también con la participación de la doctora Brenda Crafty Ramírez. Ella es médico internista e infectólogo, labora en el Instituto Nacional de Ciencias Médicas de la Nutrición Salvador Zulvirán desde el año 2007. Es investigador titular en la clínica de VIH-Sida en dicho instituto, miembro del Sistema Nacional de Investigadores, nivel 2, SNI 2, miembro del consorcio de CISIDAT, investigadores de CISIDAT desde el 2011 y secretaria del mismo del 2013 al 2018. Fue presidenta local de la Conferencia Mundial Científica sobre VIH-Sida el año pasado, que se llevó a cabo en la Ciudad de México. Además, colabora en diversas colaboraciones internacionales de investigación como IDEA, Casanet, HDB, ICONA y la Fundación Huésped. Autora de diversos artículos a nivel nacional e internacional. Nos acompaña también el doctor Roy Willy. Él es profesor de medicina de Medicine y es jefe de la División de Enfermedades Infecciosas de Weill Cornell University. Y es médico en el Hospital Presbiteriano de Nueva York, en la ciudad de Nueva York. Él es miembro del panel de las guías de DHS. También su centro es parte del ACTG. Actualmente es el chairman de los lineamientos de las guías para el COVID. Así pues, contamos con una amplia y extensa gama de nuestros ponentes, a los cuales agradezco infinitamente nos acompañen. Le cedo la palabra al doctor Hicks, quien nos va a hablar de la terapia dual. Doctor Hicks, gracias.
Thank you very much, Leticia. I really appreciate that very kind introduction. And I want to start by saying how honored I am to be able to do this presentation on World AIDS Day in Mexico. I'd like to just take a moment to pause and remember the millions of people who are currently living with HIV infection, and also the millions of people who have died from this terrible disease over the last 50 years. The first patient I ever saw with HIV was in 1980, when I was an intern working in the emergency room at San Francisco General Hospital. And I've been engaged in one fashion or another with HIV care for the last 40 plus years. In 1996, 25 years ago, it became clear that using a combination of 3 antiretroviral agents allowed us to control HIV replication and to add many years of life to people living with HIV. And over the past 25 years, this 3-drug therapy has become the standard for HIV treatment. But in the last few years, the availability of improved drugs to treat HIV has allowed the idea that perhaps 2-drug antiretroviral therapy may be sufficient. And clinical trials such as the Tango trial and the Gemini trial have shown that 2-drug therapy with dolutegravir and lamivudine may in fact be sufficient. But clinical trials data are not the same as treating patients in the clinic, as many of you watching this evening well know. And so I'd like to today take the opportunity to talk about real-world evidence, both what real-world evidence is, but also what real-world evidence exists on dolutegravir and 3TC. At first, it's important to appreciate that I am a full-time employee of Vivhealtcare, and obviously my comments are influenced by that fact. But I'm going to try and do a careful job and try to present as unbiased a view as I possibly can about this issue. So the first question that comes to mind is, why do we need real-world evidence? Aren't carefully done randomized controlled trials the gold standard? Don't they show us what the right treatments are for managing HIV? And certainly they're critical to our understanding of the drugs we use to manage HIV infection. But they're designed with a very specific purpose in mind. That is to demonstrate the clinical efficacy of a treatment in a carefully defined, carefully monitored population. These trials are essential for drugs to be approved by regulatory agencies so they can be prescribed to people living with HIV. So here's an example, if you will, of the structure of a randomized clinical trial. It contains very careful entry and eligibility criteria. It randomizes people to different treatments, and it follows them at specified intervals by research staff whose job it is to make sure they follow up. This is very important information for us to have, but it doesn't necessarily represent the full spectrum of patients we're caring for in our HIV clinics. So what is the goal of a randomized clinical trial? As I mentioned, it's to show the intrinsic efficacy of an intervention under specific pre-specified conditions, and it also collects data on safety. Whereas real-world evidence, in general, measures the effectiveness of a treatment in a more routine clinical environment and may provide insights on disease burden, on unmet needs for people living with HIV, on long-term safety in populations that are different from those in the clinical trial. It may also provide data on proper implementation of a new treatment and may address issues of cost effectiveness. The data that we use in real-world evidence comes from randomized trials done in a clinical setting that differ from those that are required for regulatory approval. They may come from pragmatic clinical trials or cohort studies of patients followed prospectively. But often they come from data gleaned from electronic medical records or large cohort studies or national or regional registries and represent often a different population of patients. Where might these real-world data find application? Well, certainly, as we think about the use of a drug in our clinic, that is an important place where this might be utilized. But it's also true that real-world data can be very important to groups such as guidelines committees. Here's data from the most recent version of the Department of Health and Human Services HIV treatment guidelines panel, looking at how they derive the recommendations that are followed by so many HIV providers. And you can see that the second tier of evidence quality are well-designed trials or observational cohort studies with long-term clinical outcomes, almost the definition of real-world evidence. Now, I talked to one of my colleagues who is on the current panel to ask him what his idea was as regards what real-world evidence is and how it may be of value to persons on the panel. He told me the following. He said, I think real-world evidence is important, but first, I hate the term real-world evidence, which suggests clinical trials data may be unreal. But also, he said that he felt it was very hard to do these kinds of studies well, because the person doing the investigation may have biases that they do not recognize as they look at the data. And it may also be true that the person reading the report or studying the presentation may not understand the biases that were present when the study was formulated. He also noted that much real-world data is sponsored by pharmaceutical companies, and many pharmaceutical companies are not interested in sponsoring trials that may relate to adverse information about the products they make. They, as a lawyer might do, don't want to ask a question that they don't already have a strong idea that they know what the answer is. And as he said, the key is these studies need to be well done. His message was there's a lot of bias involved in real-world data, and we need to be cognizant of that when we take a look at real-world data. So in summary, real-world data comes from observational studies, from current clinical practice, from patient-reported outcomes. It's used to complement evidence from randomized clinical trials, and it describes outcomes that may be more representative of everyday clinical settings. It allows us to look for unmet medical needs, to ground our treatment in the reality of the kinds of patients we see in the clinic, and to provide comparative data on clinical effectiveness and safety. Now, with that background, let's take a moment to look at real-world data on dolutegravir and lamivudine. If we look at the real-world data that has been accumulated to date, we note that it goes back as far as 2016. In this slide, the rectangles that are light blue represent presented or published work about dolutegravir 3TC that have been released for public review. They include one trial in 2016, 3 in 2017, and then the pace of research expanded. At the time this slide was made, there were 4 studies in 2020 that had been presented or published, and several more have been added to this list now, showing that in total, the amount of data available as real-world evidence is considerable, and we'll take a look at some of these data now moving forward. First, we'll take a look at those real-world studies that actually were done as interventional clinical trials. And the first one is not a real-world study at all. It's TANGO, the trial of switch from persons on 3 drug regimens containing tenofovir alafenamide to either stay on that or to go on to dolutegravir 3-TC. And you can see that the 48-week data showed that 93.2% of persons had maintained virologic suppression, and there were no resistance mutations among patients who did not remain suppressed. Subsequent analyses, ASPIRE, Lamidol, Dolulam, ARTPRO, showed similar rates of efficacy in prospectively followed clinical cohorts. Now, what about looking at the issue of resistance? Here's data from a large population involving, in some studies, as many as 556 patients, and in others as few as 6. And it looks at durations of follow-up that can go for more than 1 year, as long as 2 years in some instances. And it asks the question, is there evidence of failure with this 2-drug regimen with resistance? And you can see that in most instances, the results are similar to those seen in TANGO, with only one study showing more than a few patients failing with HIV resistance. Finally, the issue of treatment emergent resistance analyzed through a large compilation of studies, both clinical trials and real-world studies, shows how infrequent that event is. And of course, one of the early concerns about 2-drug therapy compared to 3-drug therapy was how many people would not be able to sustain viral suppression and how many of them would suffer viral resistance. And as is seen in this slide, that's been a very uncommon observation. Finally, adverse events. As we noted when we were talking about clinical trials, the population in clinical trials is very carefully selected. There are exclusions that eliminate many of the kinds of patients who might discontinue treatment because of adverse events. And as a result, most clinical trials have very few persons who discontinue therapy due to adverse events. It may be more worthwhile to look at the kinds of patients that you care for in your clinic, which include older patients, patients who have pre-existing conditions, who might not have been part of clinical trials, to see if there are significant differences in the proportion of persons who discontinue 2-drug therapy because of adverse events. And you can see in the clinical trials data, the proportion was up to 3.5%, as was seen in the TANGO trial in the first 48 weeks. In real-world data, the numbers are a little bit higher, but they're all less than 8% with follow-up periods that can extend to 2 years, as is seen in this group of 7 studies under the heading Real-World Studies. So that's a lot of data, and sometimes it's hard to look at individual studies and make sense of it all. Might we be able to combine all this information and look at it in a more combined way to see what the data shows us? At the virtual World AIDS Conference that was intended to be held in San Francisco and Oakland in July, a meta-analysis of data from real-world cohorts was combined to try to analyze this in a more comprehensive way. And Dr. Gulick will talk about some other information that was presented at this conference, but this is quite an up-to-date compilation since it was presented less than 6 months ago. When reviewing the availability of studies and ensuring that they had sufficient information to combine in the meta-analysis a total of 12 trials involving more than 3,000 patients were examined and chosen to allow combination of the data in this meta-analysis. There was one study that was reported in treatment-naive patients. So that was not included in the meta-analysis since there's nothing else to combine it with. But the remainder of the studies were done in treatment-experienced patients and included a switch to the two-drug regimen. So these are the studies that are included in this meta-analysis. If you're someone who is familiar with modeling of data and meta-analyses, it's worth mentioning that the approach used was a so-called random effects approach. However, there will also be data presented using a fixed effects model. The data are displayed with these forest plots, also known as point and whisker plots. And you can see here that this is the analysis of viral suppression in the studies that were included in the meta-analysis. The squares represent the results from individual studies, and the whiskers represent the confidence intervals, 95% confidence intervals. And you can see that for the 48-week data, the overall rate exceeded 85% suppression, and at 96 weeks, it was 85.5%. So overall, virologic suppression, both at 48 weeks and 96 weeks, appeared to be good. What about the flip side of that, virologic failure? In the same kind of a display, we see the various results here, and note that viral failure at week 48 was identified in 1.3% of the persons in these studies, and at week 96, it was only 2%. So most of the people that did not have virologic success were actually people who had dropped out of follow-up, who didn't have data points at the time that was measured, or had other reasons for not contributing to the result. The proportion that were virologic failures was actually quite low. Next, let's look at discontinuation rates. Here we see that the discontinuation rates at week 48 and week 96 were 10 and 12%. Real world data, patients not staying on trials, staying in, switching to alternative regimens because of apparent side effects is not an uncommon phenomenon, as you know from your own clinical practice. If we look at these data in a chart, it looks something like this. First, the viral suppression based on the FDA snapshot approach shows at week 48, 86% of persons are suppressed, and at week 96, it's 82%. The on treatment, not counting people who've dropped out of the study, but having a denominator only of people who have data points at week 48 or week 96, shows that the efficacy is quite strong, 98.9 at week 48 and 97.6 at week 96. And as we noted, viral failure rates of 1 and 1.9% are consistent with that seen in clinical trials. Finally, the overall discontinuation rate was about 12% at week 48 and just over 15% at week 96. So this meta-analysis suggests that dolutegravir 3TC was both effective and durable, with low rates, relatively low rates of discontinuation in virologically suppressed treatment-experienced people living with HIV in clinical practice. And these results appear to be consistent with those seen from previous real-world evidence analyses, as well as from phase 3 clinical trials. But clearly, we continue to collect data, more long-term data, larger number of persons, to ensure that the data we believe to be true is in fact verified by additional studies. Finally, I'd like to cover one very recent study for two reasons. First, it's an excellent example of real-world data. Secondly, it's very up-to-date since it was presented at the HIV drug therapy conference in Glasgow earlier this year, just 2 months ago, and it's a fairly large cohort. These data come from a number of clinics working together in the Federal Republic of Germany. The study is ongoing and is called the URBAN study. It's a prospective, non-interventional, 3-year cohort of persons starting antiretroviral therapy and pre-treated patients who switched to dolutegravir plus 3TC. The choice of switching or initiating a 2-drug regimen was done in accordance with the labeling instructions, but also was done completely in the clinical decision-making of the healthcare provider. It was not mandated by any study. For this very first analysis of the URBAN cohort, the full analysis set that was presented included persons who had at least 6 months of follow-up, with a documented month 6 follow-up visit with the window, as you see, between 4.5 and 9 months. But it also included anyone who had prematurely discontinued the 2-drug regimen. In addition to the efficacy of the trial, also collected were patient-reported outcomes using the HIV symptom distress module or the treatment satisfaction survey. The cutoff for viral suppression was 50 copies, or in persons with a viral load less than 200 but greater than 50, they were counted as treatment success if the following viral load was less than 50, identifying the low-level viral replication as a blip. And adverse drug reactions were categorized by standard medical dictionary considerations. So let's take a look at this data. This is a large trial, as I mentioned. It involves a number of clinics in Germany. At the time of the presentation, 367 persons had been enrolled in the cohort, and there was a full analysis group of 307 patients that had appropriate data through at least 6 months. The vast majority of them were persons who switched to dolutegravir 3TC, and only about 8% were people who initiated dolutegravir 3TC. Now, as is unfortunately the case in many clinical studies, the majority of patients were men, 93%. So the data available on women is limited by the small numbers. In contrast to the TANGO trial, where persons were on their initial regimen or had only one previous switch not related to virologic failure, in the URBAN trial, about a third of the patients had actually been on more than 3 antiretroviral regimens previously. And not all of them had virologic suppression at the time of the switch, about 96%. Among treatment-naive patients, the pre-treatment viral load was around 37,000 copies. The first question they asked was, if people start on this or switch to this, do they continue to take it for an extended period of time, or do they make a rapid switch because of intolerance, because of virologic problems, or other issues? Their estimation over 6 months was that 95% of the persons who initiated therapy with dolutegravir 3TC remained on the regimen, with 5% discontinuing for a variety of reasons. That represents 15 of the 307 patients for whom data were available. The most common reason were adverse drug reactions. There were 2 persons who were discontinued because of virologic failure, a term that was extracted from the medical record and was presumed to be a definition by the provider, not necessarily a study definition. In the one patient in whom resistance testing was done, there were no resistance mutations identified. In the other patient, an integrase resistance test was not performed. One patient withdrew consent, another chose to get off, and finally a third had their doctor choose to take them out of the trial. Adverse event data, 22 adverse events in 17 patients. Remember, this is out of 307 patients. So the proportion of adverse events is relatively low. There were no serious adverse events reported. And in 10 patients, the adverse events led to discontinuation of the regimen, with the most common cause being depression in 3 patients, or 1% of the cohort. There was weight gain in the population in people who were treatment naive. At the end of 6 months, the median weight change was 2 kilograms, while in those who were switching to dolutegravir 3TC, the increase was 1 kilogram. There were no discontinuations due to weight gain in this group. Now, what about effectiveness? Remember, we said clinical trials represent the efficacy of a regimen in a carefully defined population. What about the effectiveness of this treatment in this large clinical population from a variety of different clinics? You can see here that at 6 months, among persons who switched, those who were pre-treated, 232 out of 248, or 94%, had sustained virologic suppression. Among the 21 persons who initiated dolutegravir 3TC as their first regimen, 19 or 90% achieved virologic suppression. And you can see that there is one patient in this initial group who had a viral load greater than 200 copies, while there were no persons in the treatment experienced population who switched who had a viral load greater than 200. There was, however, that one discontinuation due to virologic failure per the investigator's discretion, and you see a small smattering of discontinuations due to adverse drug events or being lost to follow-up. Now, what about the patient-reported outcomes? Here we see the results from both the HIV symptom distress module and the HIV treatment satisfaction testing. The symptom distress module in pre-treated patients showed a reduction in the amount of symptom distress of about 3.1 units, with an interquartile range of -8 to +1, a value that was significant in indicating less symptom distress in the people who switched to dolutegravir 3TC compared to what they reported prior to the switch. In treatment-naive patients, the number is larger, representing 4.6, but because the number is only 25 in total, that does not reach statistical significance. But I think it's fair to say that either initiating dolutegravir 3TC or switching to dolutegravir 3TC was associated with a reduction in symptoms probably related to being HIV positive. What about treatment satisfaction? This is, of course, only applicable to those who are already on treatment. And you can see that there is an improvement in the score from 53.4 before the switch to 56 after the switch, a significant improvement in satisfaction with the regimen after going from a previous regimen to the two-drug dolutegravir 3TC combination. The treatment satisfaction overall in the treatment-naive patients was also high, 54.6. So the authors of this study concluded that dolutegravir 3TC showed a high level of acceptance in treatment-naive and pre-treatment patients with persistence on therapy of 95% through the first 6 months in a variety of different clinical settings in Germany. The viral suppression rates with this regimen at the 6-month mark were 90% in a small number of treatment-naive patients and 94% in the population of patients who switched to dolutegravir 3TC. And as we just noted, these patients reported improvements in symptom distress and treatment satisfaction over the first months of treatment. Now, critically, this is only 6 months of follow-up. This is actually earlier than most clinical trials report results. So I think the strength of this is the size of the cohort and the carefulness with which the data was obtained. But I think it will be important for us to look for longer-term follow-up in the urban cohort as time goes on. Well, let me summarize then what we've talked about as relates to real-world evidence for dolutegravir 3TC. First, I think we showed that real-world evidence provides important data that differs from that seen in clinical trials. It measures effectiveness in actual clinical settings versus the efficacy of a particular treatment in a carefully described setting as we see in clinical trials. The populations of persons living with HIV included in real-world evidence have very few inclusion and exclusion criteria, and so they capture the value of a particular regimen in a broader population of people living with HIV. And also importantly, this is data collected in a real clinic, not by a careful, independent, separate research staff, which I think adds some validity to the results that are being seen. We've seen that real-world evidence can be important in the establishment of HIV treatment guidelines, that the real-world evidence for dolutegravir 3TC is currently extensive, but is also growing and will become larger as time goes on, as additional studies, both those sponsored by Vivhealtcare and those done independently by investigators, accumulate. To date, the real-world evidence aligns well with the clinical trials data, particularly in the switch setting. And obviously, real-world evidence will continue to accrue and will hopefully be useful in confirming the role of dolutegravir 3TC as an important option in the treatment of people living with HIV. Well, as I mentioned at the start, I'm honored to be able to have given this presentation today. I think it is a demonstration of your commitment to excellent care of people living with HIV, that you would give of your free time on December 1st, 2020, when so many other things are going on, to hopefully receive information that will allow you to optimize the care of people living with HIV in your own clinical setting. And I would like to thank you so much for joining us today. Thank you.
Muchas gracias, doctor Hicks, por su presentación. Les recuerdo que no hay traducción simultánea. Esta grabación se subirá a la página de CISIDAT en 48 horas y ustedes podrán elegir en la página la repetición del webinar, ya sea en el idioma original o bien con traducción simultánea en la repetición. También les recuerdo que las preguntas para todos los ponentes se harán al final. Les pido que las posteen en la sección de preguntas y respuestas que está en la plataforma y las abordaremos al final de cada ponente. A continuación, le cedo la palabra a la doctora Brenda Crafty, quien tratará el tema de la sindemia COVID-VIH. Brenda, adelante.
Muy buenas noches, y si me habilitan, por favor, para poder compartir mi pantalla. Antes que nada, quiero agradecer a CISIDAT por la invitación. No entiendo muy bien cómo es que me volvieron a invitar, porque creo que la última vez que me invitaron di el peor discurso de mi vida, pero claro que todo en la vida te da lecciones y te hace ver las cosas con perspectiva, y de esa misma forma yo también quiero hacer mención sobre el día tan especial que es para todos nosotros, el día 1 de diciembre. Creo que no solo se trata de hablar de las personas que viven con VIH y de las personas que hemos perdido durante todos estos tiempos, sino que también después de este año tan difícil en esta pandemia, creo que es importante reflexionar sobre cómo, uniendo las fuerzas entre académicos, sociedad civil, pacientes, activistas y científicos, podemos lograr grandes cosas. O sea, el VIH ha sido un ejemplo de programas enteros de salud pública, formas de analizar datos. Y creo que hablar de todo eso, como dije al principio, de las lecciones y las enseñanzas y las perspectivas, es algo que a mí me da esperanza, sobre todo en estos tiempos tan complicados. Y finalmente quiero decir que para mí ha sido un privilegio que he dedicado toda mi vida profesional a esta rama de la medicina, que es atender y investigar sobre sobre esta enfermedad del VIH, y además que me ha permitido conocer gente maravillosa como la gente que está aquí en el panel, y para mí también es un honor compartirlo, así como también en el camino he tenido grandes maestros y alumnos, y pues bueno, creo que tenemos que seguir luchando por un mundo más incluyente, diverso y equitativo para la salud y en general. Entonces sin más, voy a compartir mi pantalla, que espero que estén viendo en este momento. Y me dicen si la ven. Yo no tengo ningún conflicto de interés para esta ponencia. Entonces, sí, ok, gracias. El contenido de mi charla irá de esta manera. Voy a hablar primero de una pequeña introducción, la situación actual de la pandemia del COVID, luego un poco del VIH y el impacto de la infección por COVID en las personas que viven con VIH, así como viceversa, ¿no? Y finalmente voy a llegar a ciertas conclusiones que seguramente podremos discutir al final de las presentaciones. Entonces, como ustedes saben, el virus toma su nombre por la apariencia, ¿no? Tiene una corona. Estaba yo viendo que en México están haciendo en las panaderías un pan que tiene muchos piquitos y le llaman pan coronavirus, que solamente suceden esas cosas en México. Pero efectivamente, esto no tiene mucho que se describió así. Y los primeros casos de la enfermedad de coronavirus SARS-CoV-2 fueron descritos justo en estos tiempos. Creo que el primero fue en noviembre del año pasado, y después en enero se identificó ya el virus y se le puso el nombre, y fue el 30 de enero cuando la OMS consideró como emergencia de salud pública de importancia internacional, y finalmente el 11 de marzo se declara la pandemia. Entonces, hablando de la epidemiología, estos son datos que presentan diariamente en el informe técnico la Secretaría de Salud y como ven, el continente americano es el más afectado por mucho, ¿no? Donde Latinoamérica contiene a los países con mayores dificultades para manejar la pandemia y donde vemos que casi 60 millones de personas han sido confirmadas a nivel mundial. Y de estas se ha reportado en este momento una letalidad cercana del 2.4%. Vean también, perdón, cómo esta tasa de letalidad pues se incrementó en los momentos de colapso de los sistemas de salud cuando tomó por sorpresa sobre todo a los primeros países y a los países probablemente de menos recursos, pero esto ha bajado conforme hemos aprendido, ¿no? Es importante siempre decir que el aprendizaje y las lecciones nos dan herramientas y es este tipo de webinarios donde podemos adquirir estos conocimientos para mejorar nuestras reflexiones y nuestros conocimientos acerca de una enfermedad y así aplicarlos en la atención y encaminar la investigación que realmente va a aportar. La situación actual de la pandemia en México es realmente preocupante, ¿no? Aquí tenemos ya, pasamos los 100,000 muertos muy recientemente y ha sido muy doloroso tener esta noticia, si bien probablemente para muchos de nosotros que sabemos cómo funciona el sistema de salud de nuestro país, donde ya estaba de por sí colapsado, ¿no? Que tenía muchas carencias, con poca inversión en las últimas décadas, pues claramente cuando lo ves en más de 100,000 mexicanos muertos, ¿no? Y de estos vemos que la letalidad es realmente alta comparada con otros países y que además la mediana de edad es mucho más baja que en otros países y que está relacionado esta enfermedad con factores de riesgo que en nuestra población son meramente prevalentes, ¿no? Tenemos una capacidad de normalizar el sobrepeso, 70% de nuestros mexicanos viven en sobrepeso u obesidad y aún así cuando le preguntamos a los pacientes si padecen alguna enfermedad te dicen que no y le sacas el índice de masa corporal y lo tienen en 30. Entonces, creo que esto también nos debe de hacer reflexionar hacia dónde debemos encaminar nuestros esfuerzos para un México más saludable. Pero como ven, pues las ciudades más apretadas son donde realmente han sido más afectadas y pues de aquí la Ciudad de México pues es de las más afectadas, ¿no? Aún así, con este registro sabemos que hay un poco acceso a las pruebas y que entonces esto también hace que sepamos perfectamente que hay un subregistro. Así se ve a lo largo del tiempo, la positividad es la raya en amarillo y nuestro primer caso reportado en México fue el 27 de febrero, ¿no? En marzo, a principios de marzo, los institutos de salud, yo trabajo en nutrición, pero también nuestros compañeros del INER, se decidió que se convirtieran los hospitales a solo atención de COVID y esto pues ha representado todo un reto para todo el personal que aquí laboramos, pero también para todas las personas que aquí se atienden por otras razones que no son COVID, ¿no? Y también desde el 16 de marzo la Clínica Condesa dejó de dar consultas de manera habitual, sí daba servicios que voy a hablar más adelante, pero esto ha dificultado y desde luego ha impactado la atención de las personas que viven con VIH. El 21 de abril, por decreto nacional, se hizo el bloqueo del país y se hicieron ciertas reaperturas a partir de mayo y en junio ya se hizo la apertura en casi todos los estados. Esta es la curva de letalidad y como ven, pues las defunciones varían mucho día a día, en diferentes semanas porque se trata del registro que cada una de las entidades, nuestro sistema de salud está fraccionado y esto hace que el sistema de captura funcione de manera distinta. Sin embargo, pues creo que pues estos son los datos que tenemos y no son nada alentadores. Ahora voy a hablar la pandemia de VIH a nivel mundial, para luego ver cómo convergen estas dos. Y pues el año pasado 25 millones de personas tenían acceso a antirretrovirales de los 38 millones que se estiman que viven con VIH, y 690,000 personas fallecieron a causa de enfermedades relacionadas al VIH o SIDA, ¿no? Y 7 millones de personas no sabían que vivían con VIH. Como ven, todavía sigue habiendo un rezago más en algunos países que otros, pero nuestro país es uno de ellos, que a pesar de que tenemos acceso a pruebas rápidas y cada vez más desmedicalizaciones de las pruebas, autopruebas y mecanismos para que la gente se haga de manera regular las pruebas, sigue habiendo una brecha importante en el diagnóstico. Y bueno, esto sigue siendo importante en las mujeres embarazadas, aunque el estatus lo conocen más las mujeres embarazadas, porque en muchos países es una práctica rutinaria, aunque en otros no hay tanto control de esto. Entonces, este es el reporte epidemiológico que hace el CISIDAT, y vean cómo hasta el segundo trimestre del 2020, solo 54%, lo cual semeja mucho al porcentaje a nivel mundial, cuenta con antirretrovirales. La epidemia en México es una epidemia concentrada principalmente en hombres que tienen sexo con hombres, en mujeres y en mujeres transexuales, trabajadores sexuales principalmente, ¿no? Entonces vean cómo es una epidemia que está predominantemente en hombres y en una menor proporción en mujeres, pero esto varía de acuerdo a los diferentes estados y las diferentes prácticas sexuales y el acceso a las herramientas de prevención que tienen cada uno de ellos. Entonces, por ejemplo, en los estados que tienen más pobreza, pues sabemos que ahí la relación hombre-mujer es mucho más pareja, ¿no? ¿Cuáles son los efectos de la infección de VIH en la enfermedad por SARS-CoV-2? Bueno, pues desde un principio lo que nos dijeron es que, bueno, las personas con VIH podrían tener peores pronósticos que con la COVID. Pues esta fue la pregunta crucial, y teóricamente a todos se nos antojaba decir que sí. ¿Por qué? Pues porque son pacientes, discúlpenme, que muchos de ellos son inmunosuprimidos. En nuestra región es frecuente el diagnóstico tardío, y por tanto entonces podríamos estar ante una situación donde a lo mejor muchos de nuestros pacientes con CD4 bajos podrían estar afectados más severamente, ¿no? Entonces, podría ser un factor de riesgo para tener COVID más severo, pero también de adquirirlo, ¿no? Pero también la otra teoría es que, pues, las comorbilidades como la enfermedad cardiovascular, pulmonar, ¿no? Y las metabólicas podrían ser más, dado que ya es una enfermedad controlable y que estas enfermedades no definitorias de SIDA, ¿no? Y la multicomorbilidad, pues es un fenómeno más frecuente, ¿no? En el VIH, y que por tanto entonces pudieran ser más afectados, ¿no? Entonces, ¿qué sabemos hasta ahorita? Bueno, al menos en Europa y América del Norte, el VIH no parece aumentar el riesgo de SARS-CoV-2 ni predispone a malos resultados por COVID, ¿no? Y hay algunos estudios que mencionan esto, y voy a analizar cada uno de ellos porque más recientemente tenemos la información contraria, ¿no? Entonces, las personas con VIH y COVID tienen alta prevalencia de comorbilidades. O sea, que si bien el VIH per se no es lo que lo provoca, si es que tienen comorbilidades, eso sí puede condicionar a que sea el principal factor de que tengan mayor mortalidad. Entonces, por otro lado estaba la pregunta, si algunos de los antirretrovirales que toman las personas que viven con VIH pueden tener, que son antivirales, pueden tener cierta acción en el coronavirus, y esto favorece que les fuera mejor. Bueno, pues por eso en muchos de los ensayos clínicos que se hicieron a principios de este año, y muchos de los intentos por dar tratamiento, se utilizaron inhibidores de proteasa, para poder tener cierto efecto en la enfermedad por SARS-CoV-2, pero luego cada vez empezó a haber más información al respecto de esto. Este es un estudio muy interesante que nos ayuda a contestar una de las preguntas que estamos haciéndonos previamente, ¿no? Este estudio que se publicó por la excelente investigadora Julia Del Amo, publicado en Annals of Internal Medicine ya hace algunos meses. Ellos, lo que ellos reportan es que en España el 90% de las personas que viven con VIH están en antirretrovirales. O sea, ellos sí tienen una proporción de personas en antirretrovirales muy alta y la gran mayoría están en inhibidores de integrasa, ¿no? En este momento. Y ellos tenían como objetivo describir la incidencia y gravedad de la COVID de acuerdo al régimen. Y entonces eligieron a 60 clínicas de VIH en España entre el 1 de febrero y el 15 de abril, un periodo corto, y de las 77,000 personas que vivían con VIH en ese momento atendidas en estas 60 clínicas, estaban en tratamiento 65% de ellos y 95% de estos estaban en supresión virológica, ¿no? Entonces se evaluaron el riesgo por personas, por 10,000 personas de hospitalización, ingreso a UTI y muerte. ¿Qué fue lo que sucedió? Bueno, aquí están 236 de estas, 77,230, o sea, menos del 1% de los que tuvieron COVID. Registrado en esta base de datos. De estos, el 64% requirieron hospitalización, 6% de terapia intensiva y 8% de muerte. La gran mayoría eran hombres, o sea, ser hombre sí era uno de los factores asociados a peor pronóstico, sobre todo aquellos que tenían mayor edad. Y esto ya no nos sorprende. En aquel momento, pues sí, ahora ya entendemos que esto es consistente con muchos de los estudios que se han hecho. Y finalmente analizaron el tipo de tratamiento y vean cómo aquellos que estaban con tratamiento a base de tenofovir en tricitabina tenían una menor proporción de estar en terapia intensiva y de muerte. Y esto ha inspirado a que investigadores españoles evalúen el uso de esto, que es lo que usamos en el PrEP oral, ¿no? Para hacer como el PrEP para COVID en personal de salud, y es un estudio que está en este momento reclutando. Entonces, ellos concluyen que el riesgo de diagnóstico de VIH el riesgo de diagnóstico de COVID en personas con VIH no fue mayor que en la población general, y que el tratamiento con tenofovir y tricitabina confería probablemente a un menor riesgo de enfermedad grave en comparación con los demás, pero no analizaron bien las comorbilidades en los grupos y esto pudiera ser distinto, ¿no? O sea, alterar un poco o cambiar un poco la perspectiva de estos resultados. Sin embargo, es una población muy grande y es un análisis muy interesante. Ahora, en los Estados Unidos, este es el estudio más grande que yo encontré, también publicado recientemente, hace como unos dos meses. Fue realizado en Nueva York, de donde es uno de los invitados, el doctor Bullock, del 2 de marzo al 23 de abril. Y ellos vean lo que hicieron. Ellos, de las cosas que sí evaluaron fue edad, índice de masa corporal y sexo, ¿no? Y lo que ven es la proporción de personas que viven con VIH y sin infección por VIH, ¿no? Y entonces, vean, perdónenme. Y o sea, parearon la muestra por estas variables y vean cómo en realidad no se encontró una diferencia entre los diferentes desenlaces, ¿no? Admisión a terapia intensiva, el requerimiento de ventilación mecánica invasiva, progresión de una radiografía anormal, eventos cardiovasculares, tromboembolismos pulmonares, ¿no? O tromboembolismos generales y muerte, ¿no? O sea, no se encontró una diferencia entre aquellas 21 pacientes y aquellos que se parearon, ¿no? Ahora, si se analizan la de la Corte de Veteranos, la VAX, que es una corte bastante conocida, vean cómo este es un estudio prospectivo de personas con VIH y personas infectadas con COVID, ¿no? Entonces, en realidad, de esta corte de 7,500 personas, ¿no? Se encontraron 253 personas que viven con VIH y que es que es muy sensible esto. Igualmente se separaron aquellos que tenían VIH positivo con COVID, VIH positivo sin COVID, ¿no? Discúlpenme. VIH negativo con COVID y VIH negativo sin COVID, ¿no? Entonces, así fue como dividieron los grupos y vean en realidad cómo lo que nuevamente analizando los diferentes desenlaces de hospitalización, admisión a terapia, intubación y muerte, vean cómo en realidad ninguno parece ser un determinante de mayor riesgo. O sea, el VIH no parece tener un efecto importante en un desenlace desfavorable en comparación con los pares que no viven con VIH. Y finalmente, este es un estudio mucho más reciente, este es un estudio únicamente en el Reino Unido que viene a contradecir un poco lo que se dijo en los estudios previos. Vean cómo aquí ellos únicamente es una población en el Reino Unido, captura datos prospectivos en un estudio que está conducido por gente de la Organización Mundial de la Salud y compara a los pacientes hospitalizados con o sin VIH en el 2017. O sea, va hacia atrás, ¿no? Entonces, de 47,592 pacientes, 122 tenían infección confirmada de manera prospectiva y todos ellos con antirretrovirales. Aquí vemos, el objetivo fue ver la asociación del estado de VIH y mortalidad a 28 días, ¿no? Y requerir, cumplir con criterios de gravedad. Entonces, vean, de los positivos y de los negativos, que fueron 26 y 32%, no se vio en cuanto a mortalidad alguna diferencia, ¿no? Sin embargo, en menores de 60 años sí que se vio la diferencia. O sea que lo que vemos aquí es que en gente joven probablemente, cuando la gente joven con COVID que no vive con VIH, o sea, si se estratifica por edad, probablemente sí pueda haber diferencia, pero en términos generales, no. Entonces, lo que ellos concluyen, los autores concluyen, que es muy interesante, es que el estado de VIH se asoció con mayor riesgo de mortalidad a 28 días en los pacientes hospitalizados por COVID, sobre todo en aquellos que son pacientes jóvenes, ¿no? Es decir, que esto lo que nos habla es que probablemente la gente joven que vive con VIH tiene más comorbilidades que aquellos que no viven con VIH y por lo tanto esto puede ser la explicación de este resultado. Ahora bien, hablando de nuestros resultados, pues este es un estudio pequeño como todas las cortes de VIH, porque en realidad no vemos que sea mucho más frecuente, ¿no? Que la población general, o sea, no parece ser un determinante para adquirir más fácilmente COVID. Y vean cómo nosotros de los 13 pacientes, o sea, nosotros de nuestra corte, lo que encontramos fueron 26 personas que viven con VIH y que se les diagnosticaron COVID, pero solamente 13 requieren una hospitalización. Y de la hospitalización, la gran mayoría tenía enfermedad moderada a grave, 4 requirieron intubación. 5 requirieron intubación, uno de ellos no se logró intubar y los otros 4 lograron extubarse de manera satisfactoria y pues vemos que la frecuencia de comorbilidades fue muy frecuente. Entonces, aunque es una cosa muy pequeña, pues estamos siendo muy consistentes con lo que está reportado en la literatura. Ahora me voy a ir, perdónenme, a hablar del impacto de la pandemia por COVID en la atención de VIH, que creo que es un tema crucial y que nos va a dar para reflexionar en los próximos meses o años, ¿no? Entonces, como sabemos, estas condiciones de contingencia ha hecho que probablemente haya gente que haya interrumpido el tratamiento, que, por ejemplo, en México, que este año se pretendía iniciar con el programa de PrEP, pues esto no se haya logrado, ¿no? Hay aumento, o sea, esto del encierro ha causado mayor, alteración o mayor índice de salud, o sea, más afección a la salud mental, ¿no? Uso de sustancias y alcohol y menor acceso a la atención médica, ya sea por miedo a contagiarse o porque verdaderamente, como nuestra clínica, pues nos convertimos en COVID y muchas cosas se interrumpieron. Entonces hay más susceptibilidad a que incurramos en prácticas de riesgo, menos testeo, menos acceso a tratamiento y por lo tanto pues un desastre que seguramente vamos a verlo en los próximos meses o años. Entonces, se estima que hay una interrupción completa de 6 meses de tratamiento, podría provocar que la estimación es que si todas las personas que viven con VIH a nivel mundial interrumpen 6 meses de tratamiento, esto va a significar un exceso de mortalidad solo por causas relacionadas a VIH de 500,000 muertes, ¿no? Lo cual es muy, muy importante porque, bueno, esto no solo es un fenómeno de VIH, sino que lo estamos viendo, ¿no? En todos los países están sacando los cálculos de su exceso de mortalidad y los números son realmente dramáticos, ¿no? Y aquí lo vemos todos los días, o sea, nuestros pacientes trasplantados que ya no llegaron de programas de trasplante que ya no llegaron a trasplantarse, los oncológicos y bueno, VIH es otro ejemplo. Entonces, vean, o sea, nosotros se había logrado mucho estabilizar la mortalidad y sabemos que si esto se había ganado una década de reducir las muertes asociadas a VIH, pero vean que si se da esta interrupción, vean cómo la mortalidad pues se puede se puede mantener así o incluso incrementarse. Entonces, realmente esto puede tener consecuencias devastadoras, ¿no? Vean lo que reporta en otros estudios, ¿no? En los Estados Unidos, cómo la emergencia sanitaria ha hecho que se reduzcan las pruebas realizadas, ¿no? Para la detección de COVID y vean cómo la falla en el PrEP, ¿no? Y la disminución de los nuevos tratamientos, pues todo eso seguramente va a tener un aumento en las personas que están detectables y transmitiendo probablemente la infección. Entonces, esto ha llevado a la preocupación de la Organización Mundial de la Salud y han hecho una encuesta en 144 países, muchos de ellos con datos incompletos, como México, pero 36 ya han reportado disrupciones de servicios de antirretrovirales y 73 de todos estos, o sea, la gran mayoría o la mitad, reportaron riesgos de disrupción en que esto representa la atención de 17 millones de personas. O sea que esto es dramático, ¿no? Creo que en el Día Mundial de la Lucha contra el VIH, todo lo que hemos logrado se puede venir abajo, ¿no? Por la otra pandemia que tenemos un poco olvidada porque estamos ante una crisis sanitaria. Entonces, vean que en esta encuesta de 2,000 personas que viven con VIH, 5 de cada 10 personas han presentado dificultades para obtener su tratamiento, ¿no? Y 3 de cada 10 tiene tratamiento antirretroviral para más de 2 meses y casi la mitad no tienen para un mes. Entonces esto pues es a pesar de que las recomendaciones en que demos provisión suficiente para que no tengan que acudir a los sistemas de salud, pues es devastador. Y luego finalmente se ha hecho esta encuesta transversal en línea a las personas LGBT en 38 países durante estos 20,000 personas y vean cómo los resultados son dramáticos, ¿no? Muchos han perdido el trabajo, ¿no? O sienten riesgo a perderlo, y esto muchas veces tiene que ver con el sistema de salud al que pertenecen, ¿no? Aquí en México, pues si tú pierdes el trabajo, ya cambias de sistema de salud y eso en sí es un reto para la continuidad del tratamiento. Entonces, todo eso impactará desde luego. Ya números concisos que se presenten, vean, estas son las pruebas de detección de VIH por trimestre en México, ¿sí? Y vean cómo, esto es en todo México, ¿no? Y vean cómo, o si lo comparamos con los trimestres iguales, pero de este año, vean cómo esto es dramáticamente inferior, ¿no? Y de los casos nuevos de VIH, pues claro que van en disminución, porque si no haces pruebas, o la gente no va a hacerse pruebas, ¿no? Si bien en la clínica Condesa, pues los servicios de testeo no se han parado, la gente va menos, ¿no? Entonces, vean, comparado con los trimestres del 2019 y los 2018, pues prácticamente la mitad de las personas han acudido al testeo comparado con los años previos. Entonces, aquí lo interesante es que vean, aquí estoy poniendo las nuevas admisiones y las readmisiones. Readmisiones quiere decir que aquellos que fueron alguna vez y se dieron de alta, pero ya nunca regresaron, ¿sí? Y estos son los pacientes activos. Entonces, en realidad, ellos todavía tienen pacientes activos porque les dan medicamento, o sea, lo tienen registrado, ¿sí? Pero no tenemos nuevas admisiones. Ajá. Pues, perdón, ellos sí tienen nuevas admisiones, pero hay clínicas, aquí esta clínica de la Condesa, pues atiende a más de 15,000 personas, es la clínica más grande de Latinoamérica, pero las clínicas que también son grandes como la nuestra, que tenemos activos 2,000 pacientes y en el CIENI, ¿no? Que son 1,500 pacientes, no hemos admitido a nadie desde febrero prácticamente. Pero aquí lo interesante es que en las readmisiones, o sea, aquellos pacientes que se habían perdido porque no habían querido venir, por renuentes a tratamiento, etcétera, no es que se fueron a otro sistema de salud. Fíjense cómo se incrementaron. Y esto es muy interesante porque creemos que es probablemente porque como en un inicio se creía que los antirretrovirales podían tener efecto en COVID o que estaban muy preocupados por estar inmunosuprimidos y estar en riesgo de COVID, a lo mejor por eso ganamos estos pacientes. Sin embargo, esto no significa que estemos bien, significa que es muy interesante cómo el miedo mueve a la población a hacer ciertas cosas. Entonces, las recomendaciones son muy claras y como vemos en la encuesta, no necesariamente se están llevando a cabo. Se debe de proveer al menos 3 meses de tratamiento, ¿no? Y debe de haber una información clara a la población de las precauciones de contagio, que aunque se están dando continuamente, pues hay mucho hartazgo y no necesario, y el uso de cubrebocas se ha vuelto político y esto ha llevado a consecuencias pues muy graves, ¿no? Debe continuarse el mismo antirretroviral, no se debe de cambiar, ¿no? O sea, mucha gente decía, se lo cambiamos porque les vamos a dar inhibidores de proteasa, ya que no funcionan y no hay ninguna indicación por la cual clínicas no están funcionando y están abocados el personal de salud a la atención de la crisis sanitaria. Entonces, en nuestra clínica, por ejemplo, nuestra experiencia es que pues nosotros fuimos designados desde marzo para la atención de COVID. Ay, perdón. Qué barbaridad. Ya me fui de largo. Se interrumpió la atención de pacientes ambulatorios, pero sí entregamos al menos 3 meses de tratamiento y ahora estamos dando más a todos nuestros pacientes. Logramos localizar al menos al 90%. Se suspendieron temporalmente la determinación de CD4 y carga viral desde marzo, pero a partir de agosto lo volvimos a reincorporar y ya tenemos el 90% de nuestros pacientes activos el año pasado ya tienen una determinación de carga viral. Se han iniciado consultas virtuales por salud mental de manera opcional, eso se ha dado durante todo el encierro, y las consultas médicas se reabrieron en agosto para ciertos pacientes, aquellos que estuvieran detectables, aquellos con bajos CD4, aquellas personas, o sea, gente con más vulnerabilidad a complicarse. Como ven aquí, pues, normalmente nosotros tenemos entre 100 y 150 pacientes nuevos por año y este año pues no hemos tenido ninguno, ¿no? Solamente hemos tenido 12 pacientes en el año nuevos, ¿no? Y ya nos percatamos que 5% ya no son indetectables y que sí lo eran antes. O sea, sí claramente hay un impacto. Las personas probablemente por temas de salud mental, por temas de abuso de drogas o simplemente por miedo a venir y recoger su medicamento, pues han dejado de estar indetectables, lo cual es lamentable. Y tenemos 62 pacientes en pérdida de seguimiento que ya estamos rastreando y la gran mayoría sabemos que ahí están, pero no han venido, ¿no? Otro de los impactos es que nosotros no tenemos PrEP en nuestro país como un programa nacional de acceso, ¿no? La única manera de adquirir a través de este proyecto en PrEP que llevaba la Clínica Condesa de manera exitosa y ha estado suspendido de marzo. Y también el tratamiento para hepatitis C ya se había autorizado y se suspendió temporalmente, no sé por qué se movió esta diapositiva, y se reabrió hasta septiembre. Y desde luego, pues todo esto va a tener impactos que ahorita no podemos saber, pero que desde luego después vamos a medir. Nosotros nos dimos a la tarea, nos vimos muy preocupados porque no teníamos dónde hospitalizar a las personas que tenían eventos definitorios de SIDA, ¿no? Y que eso sigue siendo común ahora, y más ahora porque pues como no hay testeo, la gente progresa, ¿no? A eventos, a enfermedad avanzada. Nosotros logramos dialogar con una fundación. La Fundación Carso nos proporcionó 20 camas que tuvimos disponibles entre abril y finales de julio, y aquí logramos tener hospitalizados a 33 personas jóvenes, ¿no? La gran mayoría hombres, 2 personas, 2 mujeres transgénero. Vean la proporción de CD4, pues la gran mayoría tenían CD4 muy bajos, ¿no? Y el diagnóstico pues era de enfermedad avanzada, y que de otro modo, si no se hubieran hospitalizado, si bien tuvimos 6 muertes, era gente muy, muy grave, que probablemente hubiera fallecido igual en condiciones óptimas, porque vean, las enfermedades que tenían eran de gente muy avanzada, pero que si no hubiera sido por esta hospitalización, el resto de las personas probablemente hubieran muerto. Entonces, nosotros que nos dedicamos al VIH, como hablé al principio, sabemos que las determinantes sociales son cruciales para seguir perpetuando las pandemias, como lo ha hecho con el VIH, ahora también lo vemos con el COVID. Y hay factores que luego no vemos, ¿no? Como las trabajadoras sexuales en este momento, pues del COVID, pues su acceso a la salud y sus protecciones y su trabajo en sí se han visto en graves riesgos, ¿no? Y sabemos que el distanciamiento social puede ocasionar estatus mental, abuso de sustancias y violencia, ¿no? Que es mucho más frecuente en las poblaciones marginadas, que son precisamente las más afectadas, y que como la población transgénero y gente con situación de calle, ¿no? Y todas estas poblaciones que nosotros, los que somos tratantes de VIH, conocemos muy bien, pero no es así para todas las poblaciones médicas, ¿no? Y que creo que es muy importante que en este tipo de manejo de pandemias esté involucrada gente con esta perspectiva, donde se consideran las determinantes sociales, y que la unión con la sociedad civil siempre será de utilidad para hacerle frente a una pandemia. Entonces, las conclusiones que yo podría dar el día de hoy, si me lo permiten, es que el COVID es probablemente la crisis de salud más devastadora de todos los tiempos. América Latina se ha visto afectado severamente. Las personas que viven con VIH en la mayoría de los estudios no muestran mayor riesgo a padecer COVID o de progresar a enfermedad grave. La diabetes y la vejez resultaron en mayores incrementos de riesgo de mortalidad en nuestro país por la obesidad, ¿no? Ha sido consistente en todos los estudios. Y los efectos principales de COVID sobre VIH probablemente se encuentran en el acceso a tratamiento, el monitoreo y la disminución de tasa de nuevos diagnósticos y el acceso a PrEP, ¿no? Tenemos muchas preocupaciones sobre los efectos de salud mental, uso de sustancias, inseguridad alimentaria, de vivienda y violencia, que sabemos nosotros perfectamente que pueden perpetuar esta enfermedad. Aquí no ha habido, por ejemplo, ningún apoyo para dar aislamiento temprano a las personas, y casi todas las personas que padecen COVID y que transmiten a sus familias es porque viven en condiciones de hacinamiento. Y todo eso, por ejemplo, esa perspectiva que nosotros conocemos muy bien del VIH y la tuberculosis, no creo que la necesita la pandemia del VIH. Y sin más, entonces quiero terminar agradeciendo sobre todo a mi pasante Aldo, que me ayudó a poner todas estas diapositivas, y a la doctora Lorena Guerrero, que me proporcionó todo este material. Y creo que es importante siempre mirar a la historia con esta foto. Les recomiendo este artículo, como las lecciones aprendidas siempre son de utilidad para darnos perspectiva para el futuro. Les agradezco a todos su atención y voy a dejar de compartir.
Brenda, muchas gracias por tu presentación. Les recuerdo, las preguntas serán al final para todos los participantes. Cedo la palabra al doctor Roy Gulick, que nos hablará del resumen de los congresos de CROI y Elías de este año. Doctor Gulick.
Gracias, doctora Párez, y buenas noches de mi oficina en Nueva York. Voy a compartir mis dispositivos. Ok. Reconocimos que hoy es el 1 de diciembre, el Día Mundial de SIDA, y reconocimos que hay mucho progreso con SIDA y VIH, pero necesitamos más. Y voy a cambiar a inglés ahora. To show the progress that we've made and what might be next, I'm pleased to update you on 2 recent meetings that occurred this year. The CROI meeting and the International AIDS meeting. Both of these meetings were changed to virtual meetings at the last minute. I have no disclosures. So I'm going to review for you the latest on HIV epidemiology, really focus on antiretroviral therapy, what's new in what to start, drug resistance, a new troubling side effect, weight gain, what's new in pregnancy, and then what new drugs are on the horizon. I'll then turn to prevention and briefly to cure, and then summarize guidelines for HIV in the time of COVID. Epidemiology. So every year at the International AIDS meeting, the UN AIDS releases the latest available data on the state of the AIDS epidemic worldwide. As you can see, the number of people by the end of 2019 who were living with HIV was 38 million. And as you can see in the graph, that is the highest number of people living with HIV since the beginning of the epidemic. That, of course, is good news. People living with HIV are not dying from their illness. However, even with all the progress, in 2019, 1.7 million people were newly infected with HIV. That number has been decreasing. You can see that the peak number of annual infections was in the late 1990s, when over 2.5 million people were newly affected per year. And you can see that number has been decreasing since that time. However, not likely to make the target that was set several years ago by the end of 2020. AIDS-related deaths fell to 690,000 in 2019. And you can see that this has been substantial progress in reduction of death since about the mid-2000s, where close to 2 million people died of AIDS, and now we see we're less than 700,000. And you can see that we may actually make the goal for 2020, depending on these data. really interesting information about progress was released by the Australians in an abstract that was presented at CROI. This is looking at the concept of community viremia, that is how much uncontrolled HIV there is in a community, and what is that doing to HIV incidence. So this was from a cohort study done between 2012 and 2017, and it compared men who have sex with men, either with HIV, over 14,000, and a group of over 100,000 men without HIV. They used a number of sources for data, including sexual health clinics, general medical practice, community HIV testing sites, and 3 hospitals. And these were from New South Wales and Victoria and represent about 60% of all Australians live in those 2 Australian states. From 2012 to 2017, as you can see in the graph, the number of people with detectable viremia in the community went from 29% down to 13%. That's the community as a whole. People living with HIV, the number with detectable viremia went from 17% in 2012 down to 4% in 2017. And you can see that's highly statistically significant. Undiagnosed HIV didn't really change. However, the community viral load, including all people living in the community, also decreased notably, 29% down to 13%. And then that equates to an HIV incidence rate of 0.88 back in 2012, falling to 0.22 by the end of 2017. What they concluded was decreased community viremia was strongly associated with a decrease in HIV incidence or new HIV cases. And some of this occurred before the widespread use of PrEP. So this is encouraging news to think that controlling HIV infection leads to a decrease in new infections. Also, very encouraging news came from the Kaiser insurance system, which is a big system of care in the United States. And they looked at a new estimate of life expectancy of people either living with or without HIV. They looked at a cohort of adults with HIV in care in this system over the years 2000 to 2016. And you can see they included a large number, 39,000. And then they matched them 1 to 10 with uninfected people who are also in care, just under 390,000. This study population was an average of 41 years old. It was diverse, including 5% Asians, 25% Black, 24% Latino or Latinx, and 45% white. And diverse risk groups, men who have sex with men, 70%, heterosexuals, 20%, injection drug users, 8%. And what did they find? Well, the life expectancy overall for the HIV negative group is shown in blue, and you can see that increased slightly from 2000 to 2016. But what was more remarkable was shown in orange, people with HIV. So what we're graphing here is expected years remaining at age 21. So back in 2000, life expectancy of about 60 years, but by the end of 26, that had increased to more than 70 years. And you can see the gap closes. What was more concerning was the look at comorbidity-free years. And you can see that the gap between HIV negative and HIV positive people didn't change over that time. What were these comorbidities? Well, common ones like cancer, diabetes, cardiovascular disease, liver, kidney, and lung disease. So although life expectancy improving, comorbidity-free life expectancy staying the same. Brenda reviewed this important study that was presented at the IAS meeting, looking at one of the largest descriptions of COVID-19 in people with and without HIV. And this is from the United States Veterans Administration cohort study. I won't repeat everything that the study showed since Brenda did review it, but I will tell you it's one of the largest studies yet, looking at about 30,000 people living with HIV and comparing them with 76,000 people not living with HIV and what happened with COVID. And as Brenda mentioned, people with HIV were tested more often for COVID-19 and had a slightly higher rate of positivity. But the good news was that there were no differences between HIV positive and HIV negative in terms of COVID ICU admissions, intubations, or deaths. And as Brenda mentioned, these kinds of data has been true for multiple cohort studies in both North America, including Canada, the US, and Mexico, as well as many European countries. One place in the world where there does appear to be a difference is in South Africa. And these are data from the Western Cape. They looked at a time period between March and June of this year. In this area of South Africa, which includes the large city of Cape Town, there are over 3.4 million adults living in that area. And 500,000 of them are living with HIV. About half of them are virologically suppressed on antiretrovirals. About a quarter are not confirmed suppressed on ART, and just under 20% never took antiretrovirals. They went back and looked at over 12,500 COVID-19 cases in the population, including 435 deaths. And they went back and looked at what factors were associated with death from COVID-19. And here's what they found. The risk of mortality is higher to the right of the line. Like other studies, they found that men had a higher rate of mortality than women. And I want to emphasize this is the entire population, both living with HIV and without HIV. They also found that older people had a higher risk of mortality, particularly over the age of 60 to 70. They found that diabetics had a higher rate of mortality, and those with hypertension, kidney disease. Surprisingly, they found that people with either prior or current tuberculosis had a higher rate of mortality from COVID. That had not previously been described. And most surprisingly, they found out that people living with HIV had a higher rate of mortality. Again, that's in contrast with most areas of the world. When they went back and looked, the hazard rate of death for the HIV positive people was over 2.5 times higher than HIV negative people. And that was regardless of whether they were taking ART or whether they were suppressed on ART. When they looked at it another way, they looked at people living with HIV in the population shown in orange by different years. So you can see the majority of people are age 20 to 60, with few people over the age of 60. But then they looked at people living with HIV in terms of mortality, and you can see there's a dissociation in COVID deaths in that it affected younger people living with HIV. And that's similar to what Brenda showed you in one of the other studies from the UK. Why is this? Well, an important caveat are the comorbidities, and that was not reported in this study. Back to HIV and antiretroviral therapy, what to start in 2020? Well, we saw a pooled analysis of two large studies featuring the integrase inhibitors, either bictegravir or dolutegravir, and importantly, looking at a population of people who are over the age of 50. As we all know, people living with HIV are increasing in age, and it is important to show that our regimens work as well in this population. So this abstract from Croy looked at two phase 3 studies in treatment-naive patients and compared the regimens of TAF, FTC, and bictegravir with a dolutegravir-based antiretroviral therapy regimen. That was combined either with abacavir 3TC or FTC and TAF. And the overall look was what proportion were less than 50 at the end of about 3 years. And here's what they found. So the good news was bictegravir, shown in blue, and dolutegravir, shown in red or orange, all did about the same. And you can see whether the person was greater than 50 or less than 50, over 80% of all patients suppressed below 50 copies at the end of 3 years. There was also comparable safety as well as efficacy to the overall population. And in people with detectable viral loads, they saw no resistance at all, no drug resistance in any treatment group. This study reinforces using integrase inhibitors first line. Now, Chuck Hicks looked at the issue of 2 versus 3 drug ART in his presentation. There was an interesting presentation at the IAS meeting that looked at inflammation in those two groups. This was a retrospective cohort study that took over 8,400 otherwise healthy people living with HIV who were suppressed on antivirals. And you can see most of them, 7,600, were on triple drug ART, but over 400 had changed to 2 drug ART, and over 300 to 1 drug ART, a strategy which we would not recommend today. What they looked at was the impact on inflammation in each of these groups. And this graph compares changes in different odds of having elevations in inflammatory markers, including D-dimers, C-reactive protein, interleukin-6, and other markers. And what you see here is that there was an increase in higher levels of both D-dimers and C-reactive protein in the group that switched to 2 drugs versus those who maintained on 3 drugs. Those are markers of inflammation. There were no differences in endpoints, clinical endpoints of death or end organ disease. But this is a provocative difference between 2 and 3 drugs. Where are we with drug resistance in 2020? Well, the trends in drug resistance here in the US show a decrease overall. And what you see here is a poster presented at the Croy meeting that came from over 84,000 samples that were submitted for routine HIV resistance testing over the time period of 2012 to 2018. About a third of all samples showed some degree of resistance. And so what they did in this analysis was to look at trends over time. Let's look at the graph. 2012 is shown in blue, and 2018 is shown in orange. And you can see that the majority of resistance is 1-class resistance, but this has increased over time. Every other kind of resistance, 2, 3, or even 4-class resistance, has decreased over this same period of time, which is good news. Specifically, what about the classes? Well, resistance to non-nucleosides was consistent. It was the most frequently seen resistance on resistance testing in about 3/4 of people, regardless of which year was tested. However, resistance to the other classes decreased. So nuke resistance, nucleoside reverse transcriptase inhibitors went from 55 to 41%. Protease inhibitor resistance decreased from 15 to 8%. Integrase inhibitor resistance decreased slightly from 20 to 17. And as mentioned, multi-class resistance decreased and four-class resistance was quite rare. They acknowledged these trends and said that they were most likely due to improved and more convenient ART options. But what about side effects? An emerging side effect with antiretroviral therapy is weight gain. This is best shown in a study from South Africa called the ADVANCE study. This was a study of South African people living with HIV who were antiretroviral therapy naive and randomized to either the standard of care, TDF, FTC, and efavirenz, or one of two dolutegravir-based regimens, either TDF-FTC or TAF-FTC. There were about 350 people in each arm, so a large study. When they looked at viral suppression to less than 50 out to week 96, or about 2 years, similar trends in all three. 74% suppressed with efavirenz and about 78% with dolutegravir. Looking at resistance, they did see more reverse transcriptase inhibitor resistance in people that failed efavirenz. But the notable finding from this study was weight gain. So let's take a look here. What we're looking at is average weight change over the course of 3 years. Men are on top. You can see that all three groups, efavirenz shown in green, TDF dolutegravir in blue, and TAF dolutegravir in red, all three experienced weight gain, but the greatest weight gain was in the TAF dolutegravir arm, intermediate in the TDF dolutegravir arm, and lowest in the efavirenz arm. And look at the numbers, 7 kilograms of weight gain over the course of 3 years, which is the highest of the three regimens. When you look at women, the numbers are even higher. The trends are the same. TAF dolutegravir was associated with the highest weight gain, and in this group, over 12 kilograms of weight gain over 3 years. Intermediate with the TDF dolutegravir, and lowest with the efavirenz-based regimen. Well, what are the possible strategies for addressing weight gain with antiretrovirals? And as you can see, this has been most linked to the integrase inhibitors, particularly dolutegravir and bictegravir, as well as the nucleoside TAF. So the TANGO study, which Dr. Hicks referred to, looked at continuing a 3-drug regimen with TAF in suppressed people who were randomized 1-to-1 to continue 3 drugs or reduced to 2 drugs. That is, they stopped the TAF, and this was a large study. As you know, and as he showed, 2 drugs was non-inferior to 3 drugs in terms of virologic suppression. But what happened to weight? That was the focus of this IAS presentation, which has also since been published in Clinical Infectious Diseases. And if you look at changes in weight, what you see is change from baseline was no different in the 2 groups, either the group that dropped the TAF or the group that continued TAF. They looked at it by duration of prior TAF, no difference. And they even looked at the most extreme weight gain, that is people who gain more than 10% of their weight, and saw no difference between the 2 groups. So although the study was not designed to look at this strategy, they concluded that changing to 2 drugs was not associated with weight loss by 48 weeks. What about changing from the other way from TDF to TAF? Well, that was the subject of a cohort called OPERA that analyzed over 6,900 people who were on ART with virologic suppression, switched from TDF to TAF, and then either maintained their third drug, a non-nucleoside or a protease inhibitor, or switched to an integrase inhibitor. What we're looking at is the portion of the analysis showing what happened when they switched from an NNRTI or a protease inhibitor to an integrase inhibitor. And what you see here is, this is prior to the switch, this is the time of switch. You can see no matter what integrase inhibitor they switched to, they experienced weight gain. And that was the conclusion. Those who maintained or switched to an integrase inhibitor had a similar weight gain, changing from TDF to TAF. And then lastly, what about switching off of an integrase inhibitor, perhaps to a non-nucleoside? DOR is the abbreviation for doravirine, which is the newest of the non-nucleosides. It's co-formulated with 3-TC and TDF. Again, this study was not designed to look at weight gain, but when this became an issue, they went back and looked at their data. This was a switch study, so people were on either a protease inhibitor, a non-nucleoside, or an integrase-based regimen, and then were randomized either to continue that regimen or switch to later to a doravirine, 3-TC, or TDF regimen. And the design of the study was that they either switched right away or they switched later. And it was a large study, over 650 people. So this was the purpose of the study was to look to see if virologic suppression would occur, but then when they completed the study, they went back to look at weight as well. Here's what they found. So 70% of people experienced weight gain that was less than a kilogram. So although it was increased from baseline, it was relatively mild. But the immediate switch group and the delayed switch group showed very similar increases in weight change. So you can see overall there was an increase of about 1.5 kilograms. The group that stayed on their protease or non-nucleoside or integrase, switching to doravirine did not change that. Then the group that delayed their switch to later had very similar weight gains as well. So they concluded that patients on TAF and an integrase inhibitor at baseline did not lose weight by week 48 after the switch to TDF and doravirine. So what strategies do we have for people that are gaining weight on antiretrovirals? Well, back to the basics, diet and exercise. We have no proof that switching antiretrovirals actually does anything to the weight gain, but there are a number of studies in progress. What about pregnancy? Well, we're all aware of the link between dolutegravir and neural tube defects. This was described first in a study called SAPAMO, which was a study of birth defects of antiretrovirals in Botswana that was started in 2014. And it's good to remember the reason this study was started was actually to look at efavirenz and neural tube defects. They initially reported that there was an increased incidence of neural tube defects with dolutegravir if that drug was taken at the time of conception. And the rate was about 0.3%. But what we saw at the IAS meeting was an update of these data. And what they did was to extend their data out to April of 2020. And this, they thought, accounted for about 70% of live births in Botswana. And what you see here is that the rate of neural tube defects actually fell from 0.3 to 0.19%. Well, how does that compare with other groups? The group that took no dolutegravir at conception had a 0.11 risk of neural tube defects. The group that took dolutegravir not at conception but during pregnancy was 0.04. And the control group of HIV negative women not taking antivirals was 0.07. So you see that these numbers are in range with one another, although this one, dolutegravir at conception, is numerically higher it's not a lot larger, and all these numbers are quite low. They concluded that this rate of 0.19 would account for 1 excess neural tube defect per 1,000 treated during conception. And these updated results really led the WHO to now suggest that dolutegravir is the preferred antiretroviral in pregnancy. Another important study was called VESTED, and this was sponsored by the Impact Network. This was a large study of ART-naive pregnant women living with HIV who were 14 to 28 weeks gestation from 9 countries, most of them in Africa. They were randomized to dolutegravir TAF-FTC, shown in brown, dolutegravir TDF-FTC, shown in green, or an efavirenz-based regimen. And they looked at the results. Viral load less than 200 at delivery was high in both groups, but numerically and statistically better with dolutegravir. So 97.5% of the dolutegravir group were suppressed versus 91% in the efavirenz group. So they concluded dolutegravir was superior to efavirenz in pregnancy. They did describe 2 babies who were born with HIV, both on dolutegravir regimens, one of whom of the mothers had a detectable viral load, the other didn't. And then most importantly, perhaps, they looked at adverse outcomes during the study in these pregnant women. And they found that the TAF arm only had 24% adverse outcomes, which included things like preterm delivery and small for gestational age. The number in the other groups was higher at 33%. This is important because this study now gives us data on TAF in pregnancy, which we've not had before, which suggests that it is not associated with an increased risk of ill effects. Well, what about new drugs? Conferences are always full of new drug information, and this year was no exception. So fostemsavir is a small molecule that binds to GP120 and prevents HIV from attaching to the CD4 cell. That defines a new ART class known as a CD4 attachment inhibitor. This drug, based on the result of the study I'll show you, was approved by the US FDA. So the study that led to the approval was called BRIGHT, and this enrolled a unique class of people, heavily treatment experienced people living with HIV. So they had experienced multiple failures on prior regimens. Just under 300 had 1 to 2 remaining ART classes, and they were randomized to fostemsavir at a dose of 600 twice a day or a matching placebo. And then a separate group were the most treatment advanced, 99 with no remaining options, and they were not randomized, but all received fostemsavir. And here's the results. We're looking at the proportion of people who suppressed to less than 40. I should tell you that after a week of the randomization, they were allowed to optimize their background therapy. So you can see the randomized cohort, over 50% of people were able to regain virologic suppression, and that held steady for 2 years. And even in the green group here, who were the most treatment advanced, they also responded to fostemsavir with about 35% of people able to resuppress virologically. Based on these data, the US FDA approved fostemsavir for adults living with HIV who have tried multiple meds and whose infection cannot successfully be treated with other therapies because of resistance, intolerance, or safety considerations. So this is an oral medication that is now available in the United States. Well, another exciting new drug is an injectable integrase inhibitor called cabotegravir, also known as CAB. And these are the results that were presented at CROI from the Atlas 2M study. This was a large phase 3 open label non-inferiority study of over 1,000 people. And they took people who were either on standard of care oral antiretrovirals or were on prior studies with an all-injectable regimen of cabotegravir and rilpivirine, LA standing for long-acting. And all of these patients were suppressed. The study treatment was to compare giving the injectable regimen every 4 weeks, as had been done in prior studies, or give it every 8 weeks, which would obviously be more convenient for people. Well, how did it do? The good news was no difference in virologic suppression at week 48. Every 4 weeks is shown in blue, every 8 weeks in orange. You can see 94% of all patients on the study suppressed their viral load to less than 50. Very few had detectable viral loads. Safety injection site reactions were quite common, but often mild and only lasted about 3 days on average. They concluded that giving the all-injectable regimen every other month, that is Q8 weeks, was non-inferior to every 4 weeks. You may know that injectable cabotegravir has been approved in Canada and is being under consideration at the Food and Drug Administration in the United States for approval. And be interesting to see if it makes it by the end of this year, but certainly these data are supportive. Well, a brand new drug with a new mechanism of action is called lenacapavir. This is the first in a class called capsid inhibitors. So if you recall the life cycle of HIV, the capsid is the structure that encapsulates or provides a shield to the viral RNA. And so the capsid inhibitor both prevents formation of the capsid and also disintegration of the capsid. This new drug is highly potent against HIV in the test tube, active against all subtypes, and most importantly, has decreased clearance and solubility that leads to a very long half-life of 30 to 43 days. This would support very infrequent dosing of this new kind of HIV drug. Also of interest, it's being developed both with oral and subcutaneous formulations. So another potentially injectable antiviral. The phase 1 data we saw before and was published in Nature this summer and showed that at the highest doses tested, this was a very potent agent in people, which was linked to a 2 log drop in viral loads over the course of 9 days, which certainly is a potent drug. It also has a new sustained delivery formulation that we heard about at the IAS meeting. And what we're looking at here is 3 different dosing schedules for lenacapavir. The horizontal line here is target doses. And so you can see 2 of these dosing schedules led to prolonged therapeutic or potentially therapeutic doses of this drug for as long as 6 months. So getting a subcutaneous dose of this new sustained delivery formulation led to potentially antiviral effects over 6 months. Could this lead to an all-injectable regimen that would only have to be given twice a year? Well, studies are in progress. Another new drug is islatravir. This is a NRTTI, nucleoside reverse transcriptase translocation inhibitor. It's an adenosine analog and has activity in the test tube against NRTI-resistant viruses. The half-life of the drug is also long, 50 to 60 hours, and it is available both in oral and parenteral formulations. It's been studied as part of a triple combination with doravirine and 3TC, and we saw these results from the phase 2 study that virologic suppression rates were good for triple combination and then dropping the 3TC to a double combination. Phase 3 is in progress right now in treatment naive, switch patients, and treatment experienced. Lastly, prevention. Probably the biggest news at the IAS meeting was the HIV Prevention Trials Network 083 study. This was looking at PrEP with an injectable drug, that same drug, intramuscular cabotegravir, and compared it with one pill once a day, TDF-FTC, standard PrEP. It was a large study of over 4,500 men who have sex with men and transgender women, and they were randomized to get IM cabotegravir every other month versus taking one pill once a day, TDF-FTC. It was double-blinded, so all people got injections and all people got pills. This study was stopped early because of a difference between the groups. And what's graphed for you here are new HIV infections. You can see numerically there were more in the TDF-FTC group than the cabotegravir group. In fact, 13 with CAB versus 3 times as many, 39 with TDF-FTC. Incident rates were similar, lower in the CAB group, and relatively well tolerated, with injection site reactions being the most common. They concluded CAB was not only non-inferior, but superior, and these data are at the FDA right now. And then another study came out just recently, just last month from the HPTN. It was a parallel study of IM CAB versus TDF-FTC, but this time in women in sub-Saharan Africa. So over 3,200 women participated. They were randomized. Everyone got injections and pills, and the DSMB stopped the study early. Similar results to the prior study. Fewer infections with the injectable CAB, 4 versus 34 with the oral pills, and that is statistically significantly better. So they concluded, once again, cabotegravir superior for PrEP in women in sub-Saharan Africa. Well, the Discover study was one we followed before, looking at TAF-FTC versus TDF-FTC, and we've seen these results before, but they were extended out now to 96 weeks and show similar degrees of efficacy between these two preparations. As you may know, TAF-FTC was approved by the FDA earlier this year for PrEP. They went back and looked at weight, and there was more weight gain in the TAF group in these HIV negative people than the TDF group, as shown for you here. One disappointing result on prevention was presented at the CROI meeting. This was the HIV Vaccine Trials Network, the HVTN, testing a vaccine that was related to the Thai vaccine that had shown some efficacy in Thailand previously. However, when they looked at this phase 2b3 study of this HIV vaccine, Alvac with GP120 and MF59, over 5,400 people, they could see no difference in acquiring HIV, either in women, shown in blue and orange, the vaccine in orange, the placebo in blue, or in men, vaccine shown in gray and placebo shown in gray and vaccine shown in yellow. So no efficacy, and this study was stopped early by the DSMB. Lastly, about cure, there was a patient called the Sao Paulo patient who was studied from Brazil, looking at 30 patients on first-line ART and with CD4s above 350 and virologic suppression. They added to their regimen dolutegravir, maraviroc, and nicotinamide. What were they trying to do? Well, nicotinamide inhibits HDAC, one of the enzymes that controls latency of HIV, and so they were looking for cellular latency reversal. Maravira can induce HIV transcription. So they use these two together to try to activate cells. How'd they do? Well, they did see in one patient that they could definitely, they'd been suppressed, definitely show an activation with this change. What was interesting afterwards is they eventually stopped antivirals, and this one patient maintained an undetectable level. What does that mean? Well, none of the other 29 patients showed a similar pattern, but this may be an example of post-ART treatment control. I'm not going to go into the HIV COVID guidelines because Brenda did already. So let me switch you and just tell you this, lastly, that the COVID-19 NIH treatment guidelines are a good source. I'm proud to be one of the 3 co-chairs of this, as you heard earlier, and I would refer you to these guidelines for the latest treatment information on COVID. So I want to thank some friends for loaning me some slides. And just as a preview of upcoming conferences, CROI supposed to be held in March in Chicago, and IAS supposed to be held in Berlin in July, and of course, time will tell. Muchas gracias por su atención.
Muchas gracias, Trip. Agradezco también a todos los panelistas y a los más de 100 participantes que tenemos activos al momento actual, y vamos a proceder a la serie de preguntas y respuestas. La primera pregunta es un comparativo en su apreciación de los ponentes de la pandemia de influenza, particularmente influenza española, con la pandemia de COVID-19 que vivimos actualmente. So I will translate for Dr. Hicks and Dr. Gillick. There was a question in a comparative way of the Spanish influenza pandemic and the current coronavirus pandemic. What would your considerations will be about these similarities or disparities in these 2 pandemics? Please, all.
Brenda, maybe you want to start.
Sorry, I was unmuted. Yes, so there are some similarities.
Si quieres en
perdón, en español. Las, me sigo. Es que las similitudes pueden ser que es una pandemia igual de grave, ¿no? O sea, con una mortalidad alta, y pues es una enfermedad respiratoria, es una pandemia igual y que ha sido con una proporción de muertes muy, muy alta a nivel mundial, ¿no? O sea, que no se compara, por ejemplo, con la pandemia que tuvimos de influenza H1N1 en el 2009. Lo que sí que es diferente son los tiempos, y por eso yo no lo podría para nada comparar. Creo que estamos en un momento de la información, se da rapidísimo, que tiene sus pros y sus contras, pero que eso ha facilitado la colaboración y la comunicación entre investigadores, que ha hecho que la información se tenga y vayamos aprendiendo, el conocimiento se da mucho más rápido. También, es decir, la situación de, por ejemplo, cómo antes se tardaban en los 80s en poder hacer una PCR y cómo lo podemos hacer ahora, pues no tiene nada que ver. Y de esa misma manera, la conducción de ensayos clínicos para las vacunas y los tratamientos, pues estamos en una plataforma digital, virtual y de tecnología, de infraestructura, que nos puede dar muchísimas más herramientas mucho más pronto, ¿no? Entonces, creo que no es comparable por el contexto en el que se da, pero sí que es comparable en lo devastador que ha sido.
I guess I'm not sure I understood everything you said, Brenda.
So what I said, Trip, just to make a summary, is that the setting is very different in terms of technology, science, collaboration, information, resources. It's really different, and we have advantage of that. However, it is similar in terms of how devastating and how many people has been affected by influenza in early century, last century, compared to this one.
I guess I would agree and just add that one distinguishing feature about the 1918 flu was that it affected young people, and COVID, as we know, is really age dependent, with the biggest risk of complications and death in older people. And the other difference I would say is that probably a lot of the deaths from the 1918 flu could have been related to bacterial complications like Staph aureus pneumonia. And we would not see that today because we would be treating them with antibiotics today.
Yeah, and one final point I might add is that the 1918 flu epidemic occurred in a terrible time in the world with a world war ongoing, and many, many young people confined to very small spaces. So the potential for transmission among young people was greatly amplified by the ongoing world conflict that was taking place in Europe, which I think amplified the number of people that got infected and died. And I think many of the infection control measures we know today, but don't seem, at least in the US, to do a very good job of practicing, such as distancing, the use of masks and so on, not really very well applied in 1918, perhaps not as well known either.
Gracias. Hay otra pregunta que yo lo plantearía en dos escenarios. La pregunta es, ¿cuál consideran ustedes que ha sido el mayor error en el manejo de la pandemia desde el punto de vista gubernamental en el contexto de Estados Unidos? Y Brenda, te toca en nuestro contexto nacional. So I will translate. There is a question, or what would you consider to be the major error in the management of COVID epidemic in the US? And then Brenda will talk about her point of view in this point in Mexico.
Well, I'm happy to jump in and say what's wrong with the United States. And Chuck can agree or disagree, but our biggest problem was that we did not have a federal response to this pandemic. There was very little federal leadership, and actually the leadership that we did get was often mistaken, making errors that were not based on science and medicine. So consequently, the leadership fell to our states, our 50 states. And when you have 50 states doing something, you may get 50 different responses. So some states were pretty good and other states were not good. And that's really led to our epidemic throughout this country. Chuck, do you agree?
I completely agree, Trip, and I would only add that the failure of leadership was profound, and leaders should set examples for the people they lead. And I can't think of a worse example of proper behavior than many of the leadership in the US. And that last man in the screen now, Professor Gulick, is showing us, as is Brenda about to show us, the most important and easiest thing that could have been done, and in an absurd way was not done in the US.
Bueno, a mí me toca hablar de México y es un poco comprometedor la respuesta, pero sin entrar en detalles, o sea, sí creo que el liderazgo en una situación crítica es crucial. Creo que el ejemplo, o sea, podrás decir todos los días lo mismo y podrás dar miles de consejos, pero el ejemplo arrasa, ¿no? Y creo que eso que están diciendo mis colegas tienen toda la razón, pero sí agregaría que pues somos un país del mundo con menos acceso a pruebas. Probablemente esto está cambiando, sobre todo en la Ciudad de México, pero esto nos pone en un escenario de estar actuando a ciegas, ¿no? Y desde luego, pues esto nos hace que el comportamiento, nosotros sabemos lo que es no testear en VIH y exactamente lo que está pasando ahora es justo eso. La gente, su comportamiento no es igual si se sabe positivo inmediatamente a que si se esperan 5 días en reportarlo o si no hay acceso a las pruebas, ¿no? Por otro lado, pienso que que una de las cosas que suceden en Latinoamérica y que una de mis colegas más queridas, que está en Chile, la doctora Claudia Cortés, en una de las conferencias de la Sociedad Americana de Infectología, hizo un resumen excelente de cuáles eran las guías en las que se basaban en los tratamientos médicos para COVID, y veíamos que la gran mayoría de las guías tenían un sustento científico muy pobre y que por eso en Latinoamérica se caracterizaba por dar medicamentos que no tenían sustento científico, como ivermectina, hidroxicloroquina, inhibidores de proteasa, hasta ya mucho después de que se hubiera visto la evidencia de que no funcionaba, ¿no? Entonces, esta incapacidad para poner la ciencia ante todo y que el mismo gobierno, ¿no?, o los tomadores de decisiones no evalúen lo que es la evidencia científica, ha hecho que también nosotros seamos muy malos en conducir ensayos clínicos. Los ensayos clínicos que se conducen en Latinoamérica son con poca población, son locales o son de un solo centro, que difícilmente van a aportar al conocimiento y que entonces se genere información valiosa para tomar decisiones. Entonces, creo que estamos en un rezago de investigación, hay un desprecio general de las autoridades y por tanto de las poblaciones hacia la ciencia, y esto desde luego no va a causar que nuestro país sea próspero en ninguno de los sentidos, no solo es para el COVID, ¿no? Entonces creo que hay mucho por hacer y creo que nos toca a nosotros seguir dando el ejemplo y seguir informando.
Brenda, tengo entendido que en nutrición se va a conducir un protocolo de investigación en cuanto a vacunas de COVID, un par de ellas. ¿Cuál ha sido la apreciación en cuanto a la participación de voluntarios? ¿Hay interés por participar? En Estados Unidos tienen todo un conflicto de grupos de resistencia, etcétera.
O sea, es que creo que precisamente es eso, ¿no? O sea, el desprecio a la ciencia y la poca promoción con los actos de las autoridades en favor de la ciencia promueve también que se den, o sea, es como es como echarle leña al fuego a los grupos antivacunas que tanto daño hacen, ¿no? Entonces, yo vi hoy una plática sobre vacunas en SIDA y hablé de que de 2000 hay estudios muy formales que de 2011 a 2019 se han podido prevenir 23 millones de muertes gracias solamente a las vacunas. Entonces, no verlo con esos ojos y pensar que es algo que nos va a hacer daño porque se están haciendo muy rápido, porque es una emergencia sanitaria, me parece que es no tener un liderazgo en un posicionamiento de qué son las vacunas y por qué son importantes, ¿no? Entonces, si bien la gente está actuando en espera de que llegue la vacuna, hay encuestas serias de que mucha gente hoy por hoy no se le pondría. Ahora, viéndome a nutrición en específico, los lleva el doctor Ruiz Palacios y tiene muy poco que se empezó y no te podría contestar esa pregunta de qué tanto es la participación. La que sí sé que ya empezó es la de Cancino, que es la que es por medio de un adenovirus y es la china, y las demás no sé, creo que es la de Pfizer, pero que aquí hay una logística de cómo se va a hacer el almacenaje de las vacunas por la temperatura.
Gracias. Existe otra serie de preguntas en relación a la preocupación en cuanto a los esquemas de dos fármacos en el contexto de generación de resistencia en la población mexicana que tiene problemas de apego al tratamiento, donde en muchos centros de la Secretaría de Salud solo se cuenta con cargas virales 2 veces al año, y estudios de laboratorio pues limitados. Entonces, Dr. Hicks, I will translate for this. There's a question about concerns for the development of dolutegravir resistance in the setting of 2-drug regimens. In particular, in Mexico, we have still problems with adherence, either that the people discontinue treatment or there is desabasto, ¿cómo se dice? Not proper dispense from the government of the drugs, and they might take a couple of days between they can access to the drug, especially in some institutions. What will your comments will be in that area, please?
You're on mute, Chuck.
I think you're muted, yes.
I'm sorry. I thought I was so smart to get rid of mute, but there you go. This is a very important question. It's a very good question. One of the major concerns when the idea of 2-drug therapy was first proposed was that 3 drugs are necessary to prevent the emergence of resistance. And it took clinical trials data to demonstrate that there does not appear to be a significant difference so far in 2- and 3-drug regimens as relates to emergence of resistance, particularly to integrase inhibitors. Having said that, we see that there have been cases of resistance reported for both dolutegravir and bictegravir with 3-drug regimens. So it is almost certain that resistance will occur with 2-drug regimens. I think the important question is, what are the situations in which that the risk of resistance emergence is the highest? What we have seen so far, both from clinical trials and from real-world evidence, is that failure with integrase resistance, even in people with not perfect adherence and with dosing mistakes by the pharmacy or the funding agency, it has not seemed to emerge as a major problem. In fact, I would argue that we focus so much on the few cases of resistance we see is a reflection of how much barrier to resistance there is with dolutegravir and bictegravir. So I would say if you have a person who is not very adherent, you want to have a well-tolerated regimen that you feel provides the optimum situation to avoid resistance. And if you're uncomfortable with a 2-drug therapy, I see no problem with using a 3-drug regimen. I think potentially a bigger question will be if we switch to injectable therapy with the very long half-life of the drug, whether it's the capsid inhibitor or cabotegravir, integrase inhibitor, or ropivirine. What will happen when someone on a regimen like that stops taking their medication and has a very long period of exposure to progressively lower and lower drug concentrations? So that's a long answer. My sense is that with current oral regimens, the risk is quite low, and patient selection with the proper regimen, as always, is key to the best outcomes. I would be anxious to hear Brenda and Trip offer their opinions as well.
Please.
Bueno, yo hace unos días di una plática de terapia dual y no tengo mucho más que agregar a lo que dijo el doctor Hicks. Creo que esto es una de esas áreas en donde debemos involucrar al paciente y en la decisión, sobre todo con los inyectables. O sea, no todo el mundo está para las inyectables. O sea, desde que salieron los primeros estudios LATE, hay pacientes que en mi consultorio me están preguntando ¿cuándo llegan? ¿Cuándo llegan? ¿Cuándo? Y hay gente que dice, no, yo estoy feliz con mi tableta, ¿no? Y entonces la permisividad el horario de una semana probablemente sea bastante bueno, pero a lo mejor no es suficiente para otros pacientes. Entonces, hay quienes se sienten más seguros de estar tomando diariamente su tableta. Ahora, el hecho de iniciar o no iniciar, creo que en un país como el nuestro, la frecuencia más importante de resistencia es más bien en no nucleócidos y no tanto en M184B. Sin embargo, pues sí podría representar un reto, ¿no? Entonces, creo que, sin embargo, pues ya hay ciertos estudios que en el switch, en quienes tienen más tiempo indetectables, podría ser bastante seguro, ¿no? Así es que creo que cada vez la realidad, o sea, cada vez la terapia dual es una realidad, pero sí que es para ciertas personas, ¿no? Y se deben de escoger bien. Ahora, siempre si tienes una comparación entre 3 esquemas, escogiendo bien a los pacientes, si tienes 3 fármacos y tienes 2, pues se te antoja pensar que pues uno está de más y ningún fármaco es inocuo, ¿no? Entonces, ahí en ese sentido no tiene que ver tanto con la comodidad, sino que el tiempo nos dirá si probablemente, si ya no es necesario, entonces sí estás dando un medicamento de más, ¿no? Pero yo creo que esta información que dio el doctor Hicks de información de vida real, sobre todo en el Dovato, que es el más próximo, ¿no? El de dolutegravir 3-TC, pues cada vez nos da más idea de qué es lo que va a pasar y qué tanta efectividad va a tener en la práctica diaria. Ahora, lo que más esta misma investigación se va a necesitar para las inyectables, porque pues esto representa una logística de la aplicación, ¿no? O sea, ya no es solamente el paciente y su tableta de terapia dual, sino los inyectables pues representan toda una logística que en países en desarrollo, pues claro que es importante ver cómo se va a hacer la implementación de estos fármacos.
Trip, do you want to add something?
Sure, I don't have much to add other than the 2 versus 3 drug studies are very convincing. That 2 drugs works as well as 3, and the absence of resistance, I think people were surprised at. But now we have large studies with thousands of people showing that resistance is really quite unusual or rare. I do think, and Chuck emphasized this, that in people with severe adherence problems, I probably wouldn't want to risk it with 2 drugs. But in most people, the vast majority of people, this looks like a very reasonable approach. And then I'll just add, the injectables do pose unique challenges, particularly the pharmacologic tail. You'd like to use injectables in people who have adherence issues, but you also have to make sure they come back. I think what we really need are choices for people. And some people want 1 tablet once a day, and some people want an injection, and some people may want to go back and forth between them. It's one of the strengths of our field is that we're coming up with really good choices for people and letting the patients decide what works best for them.
Totally agree. Thank you very much. And the last question will be, with this weight gain with integrase inhibitors, what will would you feel the impact will be in metabolic syndrome? This is particularly of interest in Latin America, since we have a lot of overweight and obesity, diabetes, hypertension, comorbidities in our population. So one thing, we are seeing the weight gain, but in the future, will this have an impact in the metabolic syndrome, in the comorbidities in our patients?
So this is still being studied, but what early looks at this look like the weight gain is just normal weight gain. It's not lipodystrophy, where people gain weight in unusual places. I've not heard descriptions of the metabolic syndrome yet. It seems to be, quote, normal weight gain. We have a little bit of that in the United States as well. So we don't know. I think there are a lot of unanswered questions about it. What's causing it? What do you do about it? And it could be different in different populations. I showed the data from South Africa, which could be quite different in terms of people gaining weight. They have an obesity problem in South Africa too, but weight in some people is seen as a sign of health. And so people wondered perhaps that contributed, that people were almost overeating because they had HIV and they wanted to show that they were healthy. But we need more information, really.
Thank you very much. And with that, we will conclude. So, hemos venido al final de nuestro webinar. Agradezco a todos los panelistas, Brenda, Dr. Gulick, and Dr. Hicks, por su participación. Agradezco también a la licenciada Alejandra Holguín Ramírez, quien está al frente de la División y Capacitación Educación Médica Continua en CISIDAT, a EVCON Group, que nos da el soporte técnico para la realización de este webinar, y por supuesto a todos los asistentes que nos acompañan. Esta webinar ha sido grabada y será puesta en la página de CISIDAT en 2 versiones. Podrán accesarlo en el idioma original, español e inglés, y habrá una versión con traducción simultánea para aquellos que deseen esta versión. También comentarles que este seminario tiene validez curricular. Les pedimos llenar la encuesta de satisfacción del evento y se les hará llegar su constancia con validez curricular. Y con esto, pues sin más, les agradezco, les deseo muy buenas noches a todos y gracias por su participación.
Gracias a todos por la invitación y a los ponentes y a los organizadores.
Buenas noches.
Buenas noches.
Buenas noches. Gracias.
Buenas noches a todos. Gracias.